This is a short presentation explaining what your treatment options are and the associated benefits and risks. Accompanying this presentation is an extensive written handout on which you are free to write any questions you may have. It is very important that you also read the handout in addition to watching this presentation. Firstly, I'd like to start with compression. There are 3 roles for compression. Before you undergo any treatment for your varicose veins, compression is used to minimize the side effects of your varicose veins. Varicose veins are high pressure veins and they leak. They leak fluid and protein and red blood cells and white blood cells. The role of compression is to reduce the high pressure in your varicose veins, and the secondary effect of that is to reduce the leakage. The leakage of all those substances can lead to swelling, itch in the legs, eczema in the legs, and pigmentation. It can also interfere with the oxygen supply to the skin. So the role of compression is to minimize those side effects of leaky veins. The other concern we have with varicose veins is a significantly increased risk of deep venous thrombosis. This is 4 to 7 times normal with untreated varicose veins. By wearing compression, you reduce that risk significantly. The way compression works is to augment or assist the decompression of the veins as you walk. So it reduces the pressure in the veins as you contract your muscles by assisting your muscles to create a larger force of contraction. The second role of compression is immediately following your treatment. You'll be placed usually into thigh-length compression for a period of anywhere between 1 to 4 weeks, depending on what treatment you require. Once your veins have been fixed, we then recommend that you wear below knee compression as often as possible, apart from when sleeping. We know statistically you are less likely to develop new varicose veins if you wear compression long term. So what are the treatment options for varicose veins? Well, up until about 15 years ago, the only 2 alternatives were either long-term compression or invasive surgery and stripping of the veins. Invasive surgery has a number of issues. Firstly, you have to undergo a general anaesthetic, which carries its own risks, and you have to be of a certain fitness level to be able to safely undergo general anaesthetic. Secondly, because it's quite an invasive procedure involving an incision in the groin, which is around major structures such as major arteries, major veins, nerves, and lymphatics, there are higher risks for complications such as nerve injury, lymphatic injury, infection. The stripping of the vein, as you can see in the picture, is also quite invasive, and the vein is stripped blindly, which can have adverse consequences, such as you can see in the picture, where only half of the vein was stripped out and half was left behind. The other concern with stripping is that it leads to quite a lot of trauma for the tissues surrounding the vein and also a moderate amount of bleeding. Because of the invasive nature of stripping, it requires quite a long recovery period of sometimes up to 2 weeks. The other concern with stripping is the failure rate. which has consistently, in study after study, been around 20%. 15 years ago, 2 new treatment options were investigated and the initial results published. And those 2 treatment options are ultrasound-guided sclerotherapy, as you can see in the far left corner, and then in the middle you can see endovenous laser therapy. Now I'll start with ultrasound-guided sclerotherapy. So this is a minimally invasive treatment option. It's done in the office. It requires no anaesthetic and is well tolerated. As you can see, it has a very similar success rate to surgery, that being nearly 80%. The downside, however, is that you have a 20% failure rate and there is a small risk of deep venous thrombosis of anywhere between 0.2 and 2%. There are also 13 case reports in the literature of people suffering a stroke, either immediately or within 48 hours of undergoing ultrasound-guided sclerotherapy. It is not known why this has happened, but a number of concerns have been raised, such as the volume of foam injected, and in some of these case reports, up to 70 mils of foam was used at any one time. And was there the possibility of the foam bubbles getting into the brain? If you have a hole in your heart, and anywhere up to 30% of the community can have a hole in their heart, and if you suffer with migraine and aura, such as visual disturbance with your migraine, you have a significantly increased risk of hole in the heart. But it is possible that if those bubbles get into the central system, they could cross that hole in the heart to get to the brain. The other thought is that if you suffer a deep venous thrombosis and that breaks off from the blood vessel and travels centrally, that could also cross a hole in the heart and get to the brain. It is known that not uncommonly people can suffer with visual disturbances and cough when undergoing ultrasound-guided sclerotherapy. And this is thought to be due to the release of vasoactive mediators causing this response. At the Vein Centre, we have developed our own unique technique whereby we occlude any major drainage points of the vein being treated whilst it is being treated. This means our deep venous thrombosis rate is very low at 0.2%. And it also means that very few patients suffer with side effects such as coughing or visual disturbance. A small percentage of patients, and particularly those who suffer with inflammatory conditions such as autoimmune disease, or those who have a history of thrombosis, or those who have metabolic syndrome, which is associated with being overweight and high cholesterol and high blood pressure, they may have an increased risk of inflammation after sclerotherapy. And this is usually managed conservatively with hydroid cream and compression and further walking. And occasionally, if there is any trapped blood leading to pigmentation in the skin, that can also be treated by draining any trapped blood, which is a minor procedure. So as you can see, ultrasound-guided foam sclerotherapy is quick and easy and relatively inexpensive compared to treatments such as laser. However, it does have certain downsides, such as a lower success rate than laser, a higher inflammatory response, and other side effects. Those side effects can also include allergy or anaphylaxis, which is very low in the sclerosant that we use, of 1 in 100,000. And there is also a small risk of causing an ulcer with ultrasound-guided sclerotherapy. and that is 1 in 1,000 risk. At the vein centre, we have never had a leg ulcer as a consequence of injection sclerotherapy. So now to talk about endovenous laser therapy. In 2009, this landmark paper, as represented on this slide, was published, and that compared these 3 treatment options of ultrasound-guided foam sclerotherapy, endovenous laser, and surgical stripping. And what stood out in this paper was the extremely high success rate of endovenous laser therapy. And it was at this point that I really began to take an interest in these alternative treatments. Because not only did laser have a much higher success rate than surgery, but it had a much lower risk and much lower complication rate. And this is because it's a minimally invasive treatment. It's done under local anaesthetic, often in the rooms, does not need to be done in hospital, unless you have other reasons to be admitted to hospital. It involves a 1 millimetre incision, and the laser fibre goes into the vein and seals the vein from the inside out. There is no downtime, no recovery required, and very rarely would patients even be required to take Panadol after treatment. At the vein centre, we use a particular type of laser, which is a modern laser. This has a high wavelength, it's water specific, and we use a radial fibre, which means the beam comes out like a donut. That means that the treatment has minimal discomfort. In fact, when the laser beam is firing, you should not feel it at all. It also means the risk of causing injury outside the vein is very low, particularly such as nerve injury or laser burn. At the vein centre, our success rate for endovenous laser is 99.7%. The other advantage with laser is that you don't need to fast, which means you can have a normal meal before the treatment and be well hydrated. And you can go back to pretty much normal activities straight after. We just recommend you withhold from high intensity exercise or high impact exercise or heavy weightlifting for 1 week. Because this doesn't interrupt your daily activities, because you don't need sedation, and because you don't need to fast, we have a 0 incidence of deep venous thrombosis after endovenous laser. Endovenous laser therapy is now gold standard internationally. This slide represents the recommendations in the USA, and these guidelines were put together by the Society for Vascular Surgery and the American Venous Forum. And as you can see where the red star is, because of reduced convalescence, less pain and morbidity, we recommend endovenous thermal ablation of the incompetent saphenous vein over open surgery. The United Kingdom produced their guidelines in the middle of last year, and they have also said that for people with confirmed varicose veins and truncal reflux, the first-line treatment is endothermal ablation. If endothermal ablation is unsuitable, then the second-line treatment option is the ultrasound-guided foam sclerotherapy. As you can see, surgery is now relegated as a third-line option. Because treatments such as thermal ablation have such a high success rate, it is no longer thought that compression therapy alone is an adequate alternative to intervention. Performing surgical techniques in the doctor's office requires a support team of highly trained staff. In the bottom right-hand corner, you can see a picture of Andrea, and she is actually a cardiac theatre nurse and has been a theatre unit manager for many years. She brings a wealth of experience to the practice and has been with us since we performed the very first laser in the practice 4.5 years ago. Andrea assists in the maintenance of theatre standards, and as you can see, we have a similar setup to that of the operating theatre. We use sterile prepping and draping of the leg, and you can see there's a little tube that's in the leg in this patient at knee level, and often now we will treat from the ankle if required. And this is where we have simply a 1mm incision, and under ultrasound guidance insert this small plastic straw. That allows us to access the vein without any further trauma. This is a short movie to show you how the laser works. Once the tube is inserted into the vein, the laser fibre is then inserted into the vein through the tube and taken up to the most proximal extent of vein to be treated. I then inject cold salt water with a very small dose of local anaesthetic around the vein every 10 centimetres through the skin. That fluid provides a heat barrier to protect the surrounding tissues from any heat. It numbs the vein so you don't feel the laser. It pushes any surrounding tissues away from the vein, such as nerves, to minimise their risk of injury. And it also makes the vein nice and small, so that as the laser beam comes out in that donut fashion, it's directly in contact with the vessel wall. This means that you do not require delivery of very high energy because you do not lose the energy in absorption by blood. This is one of the benefits of the system we use by using the single-use radial fibre. After the laser therapy, you'll be in thigh-length compression for 1 week, wearing for the first 24 hours. You may take it off and shower the next morning, and then you can remove it for sleeping each night from then on. You wear it in total for 7 days. It's very important that you walk for 20 minutes every day continuously, and that is to minimise the risk of deep venous thrombosis. This is a before and after photograph of a gentleman who has undergone endovenous laser therapy from the knee to the groin to treat the main truncal vein, or the great saphenous vein, that was incompetent. I've shown you this picture so that you may see how much the varicosities, or the knobbly veins, as you can see in the calf, have reduced, even though they have undergone no direct treatment yet. This is why we always start just with the laser, and we stage any further treatments such as injection sclerotherapy or removing the knobbly veins until later. We no longer do all 3 treatments on the one day or during the one procedure, because often some of those treatments become unnecessary if you do them in a staged fashion. This slide shows an ultrasound worksheet of pre-laser on the left and post-laser on the right. As you can see, a lot of the branches or tributaries are no longer yellow, even though they have not been treated. Once the laser has been done, the superficial venous system is decompressed or lower pressure compared to pre-treatment. And that means that some of the branches shrink in size and their valves start working again and they go back to normal function and therefore don't require treatment. The next stage in treatment is ultrasound-guided foam sclerotherapy. This is used to treat any residual incompetent tributaries or branches that are found on ultrasound but not visible on the skin. As mentioned before, this has an 80% success rate, meaning that 1 in 5 patients will require a second treatment for the same vein. This is a relatively painless procedure using a small needle to inject veins in multiple locations under vision with ultrasound guidance. This is performed in the rooms and usually between 1 and 2 weeks post laser. As you saw on the previous slide, an ultrasound is performed after the laser procedure, and this is usually done anywhere between 3 and 10 days after the laser. The post-laser ultrasound looks for deep venous thrombosis. It looks to check that the lasered veins are sealed, and as mentioned, looks for any tributary or branch incompetence. It is those branches that are then treated with this ultrasound-guided foam sclerotherapy. Any residual varicosities that are actually visible on the skin after the laser procedure are not directly injected. After ultrasound-guided foam sclerotherapy, you'll be required to wear your thigh-length compression for 2 weeks and again walk for 20 minutes each day for the first week. The compression is worn day and night for the first 48 hours, and then you are able to remove it for sleeping for the remainder of the 2 weeks. This is a picture of before laser and ultrasound-guided sclerotherapy, or pre any treatment on the left, and on the right, post laser and ultrasound-guided foam sclerotherapy. As you can see, the large varicosities or varicose veins are barely visible in the after picture on the right, even though these were not directly treated. So as you can see, this then means there is very little requirement often for any branches to be directly removed. This is again a pre and post picture, before treatment on the left and after treatment on the right. And in the right hand picture, this gentleman has not had any of those varicose veins removed. He has simply undergone endovenous laser therapy for the main truncal vein and some injection sclerotherapy in the calf. If there are any residual visible varicose veins, once the laser and the injections have been performed, we can then remove those varicose veins. This is again a minor procedure. It is performed in the rooms under local anaesthetic, and a small incision is made of about 1 millimetre, sometimes 2 millimetres, depending on how large the varicosity is, and the veins are simply hooked out. If you are required to undergo phlebectomies, you will then need to wear your compression stockings again for 1 week. 24 hours for the first day, and then may be removed for sleeping for the remaining 6 days. If you have any spider veins or thread veins, these can also be treated, and this requires microsclerotherapy, where each vein is individually injected with sclerosant. A very small acupuncture size needle is used, and again this procedure is performed in the rooms and is generally very well tolerated. If you undergo microsclerotherapy or spider vein treatment, you will be required to wear your compression stockings for 1 week after. Again, for the first 24 hours, and then they can be removed for sleeping for the remaining 6 days. Thank you for taking the time to carefully listen to this presentation. Accompanying this presentation is an extensive written handout going through in detail the procedures and the associated risks and benefits. At the end of the handout, there is a section where you can write questions, which we would encourage you to do. And please don't hesitate to ask the nursing staff or myself any questions or concerns you may have. Thank you.